okay, we'll give this a go, then you're more likely to make that change happen.
Okay, so blood tests coming up, and then communication and critical friends and change management, and actually that kind of process that you just talked about, Khyati, is I think referred to as having a guided coalition. You know, people who kind of work with you and come alongside you to make the idea happen. Yeah, coalitions, really important. Did Krishna have anything to add?
No, well, today's session covers it for me, really, for now. So.
Brilliant. Good. All right, so room 2. That was Maria was in that group as well. Sadia and Sabina.
Oh, hi, yeah. I just brought up a couple of topics about minor ailments and telephone triage, if anyone was doing it in our group, and if they attended courses, etc. No one's doing it, but I think there's a national course available, so I just wanted to know if anyone else has any opinions, or has anyone done any course on that. And the second one's about contraceptive pill check. Is anyone doing that, and did they have to attend another course for it as well as a clinical pharmacist?
Okay. Has anybody got any thoughts on those? We might as well do stuff as we go along. Has anybody got any thoughts on minor ailments and telephone triage? Simon?
Yeah, so can I start from the back? So in terms of contraception, there's no, tell me if I'm wrong, someone, my understanding is that
Sorry.
Oh.
I'm fine, yourself?
Sorry.
Don't I go up? Because I'm gonna make my sleep. Your room is done. Okay.
Sorry. Yeah, so what I was saying, so my view with these things is that there's no like person who's monitoring, are you competent in this, are you competent in that? You're having to make a judgment based on your own expertise. And there's no like test for every single thing. You know, you gain experience, and eventually you feel confident to do it by yourself. So it's a self testing system. I can't think of the right term.
Yeah,
in my experience, I tend to whenever I've developed anything, I will do it, try it, give it a go, and then run it by a doctor. And after you've done that a few times, you eventually realise that you're getting the answer right all the time, and you don't really need to keep running it by them. In terms of minor ailments, I don't know if there's a specific national training. There is often funding for for advanced practitioner courses. I don't know if that's what you're referring to, but I think it's beyond the normal minor ailments. That's much more looking at assessment skills rather than focusing. So it's sort of a very general training on assessment skills.
Yeah, I've seen that's like a master's level, like 2 years course or something.
Yeah, you can do masters or diploma. So if you've got a prescribing qualification, then that counts towards it. So I'm doing it at the moment. I've just done it at a diploma level. But I think the same principle applies. You know, at the very least, if a patient says they've got a new ailment, take a history, and at least you've then got experience with history taking, and then you can then pass that on to, at least when the doctor looks at it or you run it by them, at least they've got some background. You know, and there's no harm I can think of in taking history, as long as you're clear to the patient and you manage your expectations. That you'll have a list and you'll see what you can do, but you might not be able to then resolve it. My view. I don't know if anyone disagrees with that.
I have a question, Simon. A few people have been asking, because a couple of boroughs is funding the advanced practitioner course. In terms of the commitment required by the practice and the time in the practice and the time from the GPs, do you have any comments on that?
So I suppose where I am, I was having, what I would generally do is run a clinic, and then at the end of the clinic, spend some time with the doctor running through things that are important. So there already was a sort of mentoring time that was naturally built into the day. So because that was already there and there was a protected time to do that, there wasn't a great deal of change. The only other thing is that for the course that I did, you have to be watched doing certain, so they have to watch you doing various examinations and sign you off. So it's not a huge burden, but it's sort of like 10-15 minutes they have to sit with you as you do those examinations. But for most people, they have, I would imagine people have that time built into the day where they would run things by a doctor or whoever, you know.
Khyati, do you have any comments on that? Because you're very used to training practitioners, nurses, albeit nurses at St Andrews.
Yeah, I mean, I think what Simon said really holds true. You start by taking a history, and a really, really comprehensive history. And then once you start getting confident in that, you start developing your range of differential diagnoses. When the minor ailments stuff started first, and I think, you know, advanced nurse practitioners and pharmacists, when we started it, when the courses started, it didn't feel quite right, because the scope of training specified something like you can treat a cough, but you can't treat a pneumonia. But you cannot possibly do one without being able to diagnose and discount the other. Does that make sense? Like you have to be able to discount a pneumonia and be able to pick that up so that you can treat a cough when it is a cough. So actually minor ailments, although you're treating minor ailments, your range of what you need to know about is much broader than that, because you've got to be able to recognize when something isn't a minor ailment. So in terms of building on it, the good history taking and then seeing as much normal stuff as possible. And I've said this before, work up to proposing a management plan, proposing investigations plan. And then, like Simon says, very soon you'll realize that what you're proposing is really accurate. And then you can, rather than asking what would you do next, propose what you think should happen next. So then you can start building confidence that way.
Great. Okay. Room 3. So Emdad, Aisha, Sangeeta. Do you want to unmute one of you?
Hello, Sharon. Sorry, my camera's not working. It's Aisha. We kind of discussed the good things, and who was enjoying what kind of thing. We didn't have any stinky fishes.
Okay, that's good.
Yeah, so we discussed, the difference between community and primary care and things like that. Really, some bonding time. So
what are the things that were going well in your room?
Yeah, we were talking about my the fact that I had my CPPE respiratory thing this morning, and how it was difficult. The only thing we said was how difficult it was to do some consultations, which would require like respiratory skills on the telephone, and that's what we discussed that. We didn't really talk about many stinky fish, like Aisha said.
Okay.
Really.
Okay, cool. All right. Family room 4. So that's Vicky, Simon, Jonathan, Aisha, Akshita. Jonathan?
Mainly it was that I found that the last 2 weeks the workload is increased considerably. I think it's just from what Simon said, he's experiencing the same as well. So I assume it's everyone's experiencing it.
Any thoughts on how the practices have adapted to that?
Well, we lost one of our nurses as well as an HCA in the last month.
Oh goodness.
So I've been.
It's firefighting.
Yeah, very much.
Okay.
I think the problem is there's differences in how. But I think in order for practices to make the changes they need to deal with the workflow, they require a high level of experience and change management and processes and all that. And a lot of practices don't have those skills, or are very scared about making changes. And I think that's the workload is high, but it definitely could be managed better with certain changes. But a lot of people just don't feel comfortable even trying, or even know where to begin, and they feel overwhelmed. And I don't really know where you begin with that problem.
Just with the last couple of weeks particularly, so I think nationally, people have seen an increase in demand by about 120, 130% of what we'd normally expect for this time of year. In Tower Hamlets, we might see things slowing down a little bit because of Ramadan, but actually we're seeing like catch up. So the workload is higher. It's not that capacity is just reduced. The workload's higher than the system's built for in majority of cases. So, it might just be a short-term thing, and we may have to ride it out, or there might be some tweaks to make. In addition, every time you have a bank holiday, you feel it for the 2 weeks afterwards. So it's worth just thinking about the fact that you've got another bank holiday coming up, another 2 bank holidays coming up in May. And if there are any changes or any learning from the last 2 weeks just gone that you can make and tweak and apply for the next 2 bank holidays, then at least you're kind of winning a little bit more than you would have been if you'd done nothing.
Yeah, that makes sense. So that's about the team, the team coming together really, and having.
Well, even just little things for yourself. So I've just sent around an email this morning saying, I'm still recovering from the last bank holiday, guys. If in the week after the next bank holiday, you can not book any routine reviews for yourself, if you can, adjust it so it's the week after, then try your best. Like, just don't book routine stuff where you can help it. That's a small change, but it will make a big difference.
Okay. All right. We'll hopefully have a little bit of time at the end if anybody has any burning questions that haven't been answered. So that's great. Thank you everyone for participating so actively. All right, over to you and to Maria then, Khyati.
All right. Okay. So I shall start with the presentation, and then will we be able to go into breakout rooms?
Yep. While you're presenting, I'll have another look at the breakout rooms because it didn't really work very well last time.
Oh,
so, yeah.
I think it's saying that my sharing my screening ability has been disabled.
Maybe that's because. Oh, how odd. Okay, let's just go back. You do it now?
Oh. Yep. Perfect. Okay. All right. Hello, everyone. So, as you all know, we'll be talking about red flags today. And it's quite interesting, red flags are, because I feel that as pharmacists, we've got so much to offer when it comes to picking up red flags. And I think this will tie in quite nicely with some of the stinky fishes that people have mentioned earlier as well. And this will be, again, a very informal session, people to share ideas, people to share their own stories, experiences, so that we can all learn. So, okay, Zoom etiquette as always, please mute your microphones and keep your camera on if you can. And any questions, please either use the chat box or raise your hand. Okay, so the learning objectives, I feel like everybody has already seen these learning objectives. Josie put those up on our WhatsApp group. So this session will cover red flags, what are they and how to recognize them, common red flags seen in primary care by the pharmacist, how medications can actually be a good indicator to pick up red flags, and then there's like few examples and discussion points surrounding red flags. Okay, so what would you like to achieve today? If anybody at this point would like to share anything, shout out whatever they want to achieve, or just type it in the chat box, just so that at the end of the session we can have a quick look and answer any of the burning questions. All right. Okay, so let's start off with what are red flags. So red flags are specific attributes derived from a patient's medical history and the clinical exam, and they're usually linked with a high risk of having a serious disorder, so like an infection, cancer, or a fracture. It is quite important to realize that red flags are not a diagnostic test, and they don't necessarily predict diagnosis or prognosis, but are rather clinical prediction guides. And their main function is to raise the clinician's suspicions when they're combined. So once there's a symptom in isolation could be absolutely nothing and could be extremely normal, but few of them combined together can present as a red flag, and it can present as clinician gives like rise to some suspicions to what exactly is going on and whether to investigate and give treatment beyond what the patient's receiving. Okay, so the common red flags, I feel like a lot of you will have come across these common ones. So anybody age over 50, progressive symptoms, thoracic pain, past history of cancer, any unexplained weight loss and weight gain, drug abuse, nighttime pain, systemically unwell, and night sweats. So how will we identify a red flag? So there's 3 common criteria when it comes to identifying red flags. So several factors should be considered, but the main 3 ones are your duration. So when does a harmless symptom become a red flag? So clinical complaints such as your cough, tiredness, diarrhea are common in acute self-limiting viral or bacterial infections, but they can transform into red flags if they persist over a certain time frame. So over somebody who's had a cough for over 6 weeks, and I'm sure like around your GP practices and in reception areas and even like pharmacies and stuff, they have these posters up that says, oh, have you had a cough more than 6 weeks? Have you spoken to your GP about it and stuff like that? Second factor is your demographics. Age is a very important factor in determination of cancer risk, and symptoms that are viewed as red flags in older age groups may be more likely to be caused by other diagnoses in younger age groups where that particular type of cancer is rare. So we'll be talking about this later on. Like, for example, somebody above the age of 50 or 55 presenting with like a long-standing history of constipation, we would be a bit more concerned compared to somebody who's quite young. And also the third type is your clinical features. So anything presenting as not normal, which is quite ambiguous, but for the patient, for example, a lump, in particular lymph nodes, a mass or mucosal abnormality, in particular oral or rectal, or any unexplained bleeding. So particular either vaginal, rectal, or any unexplained bruising. So what are the things that we should be considering? So the clinician needs to decide if there is a level of concern, and the clinician could consider a trial treatment, but will need to monitor the patient over time and revise the management if necessary. So it could be those red flags combined. As a pharmacist reviewing those patients, you could be thinking, oh, they seem a bit concerning, but I will need to keep it. But at the moment, I don't feel like it requires, like maybe it requires an urgent referral, but I still need to keep an eye on these symptoms and review the treatment constantly. And red flags should be regularly considered and reevaluated. And it's not enough to just simply consider red flags at the initial assessment and then forget about it. They should constantly should be, as I said, reevaluated and thinking, and should be assessed whether how they are faring. Are they getting worse? Are they improving? That sort of thing. And also, if there are more concerning features, the clinician needs to consider their urgency. So is it a medical emergency, so something like a cauda equina that requires immediate action, or potential metastases, which could wait a few days but still require urgent referral? So when it comes to urgent referrals, I know that not a lot of pharmacists get involved with that, but having said that, that's not something you can flag up to the GP, and you can let them know, and you can give them the history that this is what's going on, these are your predictions, and ask any other clinician present in your practices. So I found this really helpful diagram on Physiopedia. There can be certain spectrum of flags, but they could range from like a green up to a red. Red is when combined together can mount to either a medical emergency or can mount to something like a very urgent referral. But it can be a spectrum. So for example, you can have no concerning features, you can have low or some concerning features. In all of these categories, you may want to consider the treatment, you may want to consider keeping an eye on the situation, you may want to consider repeating blood tests in a few weeks' time to a few months' time, etc. And then the end is your like high, which is your multiple concerning features, which is like emergency referral and you seek out advice. Okay, so a lot of the red flags that I mentioned before can be very specific. So like, for example, age above 50, or a constant like night sweats and stuff like that. But then what about the non-specific symptoms? So which could, as I was mentioning before, which could be almost nothing on its own, but then when you combine it together, it raises suspicion. So for example, certain combinations of symptoms, including so for example, an older patient with tiredness, weight loss, and unexplained bleeding, the general rule to follow is that if a symptom persists, even if a test shown to be negative, re-referral should be considered. Often a serious diagnosis such as cancer is not suspected until symptoms persist or worsen. So non-specific symptoms could be your just bleeding, unusual lumps, a sore that does not heal, like a skin surface, unexplained weight loss, very heavy night sweats, or unexplained pain, aches, appetite loss, fatigue, and pruritus. So I have got like 3 examples that we'll be talking through. They are sort of like a general scenario that potentially we do come across, and a lot of us do come across these type of patients, and they're really common. And most of the time we just sort of continue with the treatment. There's nothing to worry about. But then when you sort of look at the holistic picture, you sort of realize that actually there could be something a lot more sinister going on, and does that require further investigation or further referral? So I'm going to give you this case of, there's a 59-year-old male with heartburn and indigestion. He had been taking OTC Gaviscon. He was seen by a GP 6 months ago and had been taking prescribed omeprazole since. He comes to see you for an alternative PPI as he had no improvement in symptoms. Ask if he can have a smaller tablet as he's finding it hard to swallow. What would you like to know further? Or is that something that you will just change him to something else? Do you feel this is something that you need to explore and question further? So Sharon, is it possible if you can just go in breakout rooms for 5 minutes, discuss that, come back and share?
Sure.
Okay, thank you.
Right. Oh my goodness, there's a lot of people unassigned. Don't know what's happened. Okay, so some of you are going to stay in the room while I assign you to a room.
Sorry, shall I go back a slide so everybody can take a picture?
They've all gone to their room. Shall I bring them all back?
Yeah, sorry, I just realized that I've not told them to do that.
Post it on the group. I think Simon's about to, possibly.
Oh, okay.
Jonathan, someone's about to.
I'm doing it.
Someone's taking
Oh,
photos.
perfect. Thanks, guys.
I think a lot of people joined and so the breakout rooms haven't worked very well, I'm afraid, because people have been, I think maybe because of internet connection, have been. You still in the room, Khyati?
Yeah, I just stayed behind in case you wanted to catch up.
Yeah, that's good. I'm just looking, I've got too many people in this room. Just let me just have a look.
There's Vicky and Akshita as well.
Yeah. Huge number. I don't know what's happening.
You can't assign Akshita?
She's not joined, so I don't quite know what's going on.
She's not joined?
Yeah,
I am.
Oh, okay, so it's Akshita's left, okay. Let me just have a quick look.
No, Akshita's still here.
Okay, I'm going to move you to room 5 with Chandani.
Thank you.
Are you, can we pause recording?
Hi, Rena. Were you in a room? Rena P?
Yes, I was room 5, I think it was.
Oh, we're all back now.
Okay.
Rena.
So, okay, so yeah, so I was just, as I was saying, that this is a case that I'm certain that we all come across time and time again. Patients asking for their repeat PPIs, or patients been on PPIs for a long term, patients wanting a different PPI because it hasn't worked. So yes, so what I would do is, if a group can volunteer and sort of discuss like what would be the next sort of question and what would their approach be. Again, everybody sort of, as I mentioned before, red flags aren't a diagnostic tool. They're more a collection of things which sort of can raise your suspicion for something a lot more sinister. So there isn't one right approach. So if anybody wants to share their ideas of how you would go about dealing with this, any group. Sharon, you pick a group.
I pick a group. Room 3. So we've got Sangeeta, Aisha, Yvonne, Simon, Sunil. Anybody want to share your discussion? Yvonne?
So we were talking about taking a full history to find out how long they'd had the symptoms, what had already been done with respect to investigations, blood tests, PPI, how long they'd been on it, whether he was taking it, so compliance, what the actual difficulty swallowing was, kind of ruling out maybe non-sinister things like possibly just a sore throat, or that they'd always had difficulty with the tablet but only just flagged it now, and they just couldn't take a capsule. And then Simon was kind of saying about probably flagging it for a 2-week wait because of if it was true difficulty swallowing. I said I would probably want GP input because I don't do referrals, but he obviously has done referrals, so he would refer. Yeah, I think that was everything I said.
Yeah, I'd take more information, but I would say I'd have a relatively lower threshold for this one.
Yeah. Okay. Yeah, this is a really good approach, because basically what you're trying to do is, in any scenario case like this, you want to first start off with a very comprehensive and detailed history. So you do want to rule out the most obvious common things like, oh, how compliant is he? What is his drug history like? What investigations have we done? What has happened to the patient in the recent months? And another thing that I would do is also ask him about lifestyle choices as well, like lifestyle questions, like how is his first of all, my concern would be, why does he have dyspepsia, right? And then what's his lifestyle is like, his diet, alcohol consumption, stuff like that. And then I would be going more along the lines of, okay, so why is he having a swallowing difficulty? Because that does raise alarm bells, because it's all of those symptoms, so his age, dyspepsia, dysphagia, on their own, they may not be considered like red flags, but when you combine them together, in this case, it does raise alarm bells, and you do want to refer. So I think what I'll do is,
Maria, I just wanted to add, what I would do is I would apply a mnemonic called as old cards. So which stands for onset of the dysphagia, location, duration, characteristics, associating factors, relieving factors, treatment, so that you get complete picture of his dysphagia. And based on that information, look at the previous investigation he already had, for example, endoscopy, his bloods, and also maybe ask further questions. Again, more sort of red flags. Is he passing any bloods from any orifices? Because then, as you just mentioned, that combining one or two symptoms makes it sort of looks like more like a red flag. So perhaps, that's kind of takes us or streamline, in comprehensive history. And then so that then I would then, based on this all cards information or the comprehensive information, I will then pass on to the GP. So whether this patient would need a 2-week referral, or is it just that he has got a very bad viral infection, he's unable to swallow, and he's just asking for a smaller tablet or a smaller capsule.
Yes, absolutely, you're right. Anybody else have got anything that they would like to share? No? So yes, as all of you guys mentioned, yes, so red flag symptoms, again, checking their bloods. Do they have any anemia, any unintentional weight loss, dysphagia? Okay, yes, they're having difficulty swallowing, but then could there be a sore throat or a viral illness, or could it be an esophageal malignancy? Or has there been any vomiting, diarrhea, constipation, bleeding, stuff like that? And if again, this patient was over 55, and why is there an unexplained and persistent dyspepsia? So dyspepsia can, on a background of weight loss and dysphagia, may be suggestive of esophageal malignancy. And primary care investigations, you guys have all mentioned that what you would do to explore this further. But then another thing that I think what Khyati is going to explain is as well the 2-week wait referral, because I know Simon said he gets involved with referring in these referrals, but not all of us may do that. So Khyati, do you mind just explaining what that is and how you would go about doing the 2-week wait referral?
Yeah, so it's universal now really across the country, but certainly there's a pan-London 2-week wait referral forms that look the same in all your surgeries essentially. And a 2-week wait referral is a form that is sent off urgently, and it's sent to the triage at the other end for a patient to then be offered an appointment to be seen within 2 weeks. And that's sort of a national target that happens. So if this person with dysphagia is sent in via 2-week wait, they would go down the suspected cancer pathway. So it's really important that you understand and you can explain that to the patient, because often clinicians get into the habit of saying, I'm going to refer you urgently, you'll be seen within 2 weeks. And the letter or the communication they might get will have the word cancer on it, that this is a suspected cancer pathway. So it's important for all of us to kind of be wary of that. And part of the referrals will say that, we'll ask you to tick box whether you've had a conversation with the patient that there is a suspicion of cancer there. And also that they've been safety netted. So this part of the safety netting is around the process. So saying to someone that if you don't get seen or an appointment within 2 weeks, then please come back to us because something has gone wrong, something has fallen through in the process. So that's part of the safety netting. Some practices have become even more sophisticated than that and are setting up AccuRx and text messages to remind patients in 2 weeks' time, setting up a text message that pings up in 2 weeks' time to say, have you received your appointment yet? If not, come back to the GP. So when you're doing this for common issues like breast lumps, and I say common because they're one of the commonest cancers, it is up to the hospital then to review what you have sent, and then they might downgrade it to an urgent or a routine clinic based on the information. But then they will communicate that to you and to the patient as well. And 2-week wait criteria are pretty much based on NICE guidelines. There may be some nuances which are different locally, but majority are based on red flags around NICE guidelines as well.
Okay, so Khyati, would you have, when you're having this conversation with the patient, would you be quite upfront and tell them that this is what you're suspecting, and you're suspecting cancer, and this is what you would be doing?
It depends how high my suspicion is of a cancer. Okay. So if the suspicion is sort of there, but I'm not extremely worried about a patient, then I'd say, look, I need you to get investigated. The quickest way for me to get this done urgently is through a 2-week wait pathway where we send lots of suspected cancer referrals. So you will get an appointment from the suspected cancers team, and that's the best way to get seen as quickly as possible. So that might be for the ones where I'm not as suspicious. For something that looks like a barn door cancer, like a breast lump where I am really worried, I would say, look, this could be a cancer, and this is the quickest way to get it done. And I'd be a little bit more priming the patient a little bit more to be prepared for that sort of diagnosis, and maybe have a chat about, if it is a cancer, this is a treatable cancer, or this is what we can do about it, and it's, you know, good to pick it up early, and so on. So depending, you know, the whole thing, the whole reason you're referring under 2-week wait is because the suspicion is there already. But, you know, there are suspicions, and then there are high likelihoods of these things as well.
All right. Okay.
There's a question on the chat about the calcium test, testing for calcium. In the previous slide, Maria.
Oh.
The list of
yeah. So I think basically when I was looking into it, they keep mentioning calcium, and it could be due to like maybe your pituitary, or it could be any other.
It's likely, well, a lot of it's the reasons for is bone metastases. So you're looking for kind of a hypercalcemia related to bone mets potentially. So that's why you do a bone profile. For certain other cancers like myeloma, you'd see a hypercalcemia as well. So yeah, for this sort of GI cancers and ones that commonly metastasize to the bone, if I'm doing blood tests, I'd do a calcium with it for that reason.
Does anybody else want to ask any questions about the whole referral, and any other comments about this particular example before I move on to the next one?
Oh, I've got a question.
Sure.
With the various investigations listed, I presume that you probably wouldn't, that you might pick some of the maybe key investigations and do those first. So I just wondered, I suppose Khyati would probably know which ones you would go for first, if that makes sense. Because perhaps you may not start off with like an ultrasound of abdomen and things like that.
In this particular case, if you are doing a 2-week wait, you don't need to do any preliminary radiology investigations necessarily, but it would be really helpful to do some blood tests because it might help speed things along. And sometimes you need the blood tests for the 2-week wait as well. And it's useful just to know things like if they want to do an endoscopy on someone, they like to have a recent renal function test. Sometimes in the actual 2-week wait, it will ask you what their last set of blood tests are. So if you're seeing someone who hasn't had blood tests for ages, do the 2-week wait. Investigations can wait if they fulfill the criteria. Nothing's mandatory, they'll do them all, but just preempt what might be needed for things to get moving quickly. But radiology, to be honest, you can leave. Some of this other stuff is helpful, particularly if they're on the lower end of suspicion for the cancer, where you're thinking, okay, I want to rule out cancer, but I think it could also be this, this, and this. Then the other investigations can happen, like the stool test and the blood tests and so on.
Thank you.
Okay. All right. Okay. So this urgent referral Khyati has spoken about. All right. Okay. So we are moving on to our second example. We have a 63-year-old female nurse with a 5-month history of back pain. GP has asked you to review as she has been needing increasing doses of analgesia. Her back pain is making it hard for her to work. She feels tired and lethargic. A lot of people have mounted this to the fact that she's a nurse. There's a lot of like mechanical handling involved in her job. When you're reviewing her pain medicines or analgesia, what would you like to know, and whether there are any investigations would you like to consider? So if we can, let me just take a picture of this and send it to a group. And if you can go back into the breakout rooms, discuss this and come back. Is that okay? Sharon, is that okay?
Some people seem to have gone out and come back in again. Okay, I think everybody's back.
All right.
Khyati.
All right. Okay. So again, shall we pick our group?
Yeah. Should we go for room 2? No, maybe not. Room 4. So Kiloni,
that wasn't
Sidra, Aisha. Kiloni?
Yeah, so basically we said that we would investigate, I mean, because she feels tired and lethargic, we would investigate whether there's any anemia going on, any internal bleeding as such. And then and because she's had a 5-month history of back pain, which is quite a long time, we would basically find out if there is any cancerous diagnosis, so chondroitina. If there's anything like that, then we would speak to the GP, make a referral to the neurology team just to find out whether there's anything to do with that. And that's what we discussed, yeah.
Okay.
Anybody else has any other thoughts? Anything that they would like to add to that?
I guess
Any other approach?
For me, it mentions that she's been increasing analgesia. Has she been increasing opioids? Is that the reason why she's been feeling tired and lethargic as well? So I guess to investigate that a bit further as well. And also maybe the cause of the back pain. Was there something, an event that happened that caused the back pain, or is it unexplained and it's just gradually got worse? I guess just to take a bit more of a detailed history and then refer appropriately following that.
Yeah, absolutely. Yeah, so in every case you have to, and as Khyati was saying in the beginning as well, that you have to start with a comprehensive history. You may feel that some patients they just want you to quickly, if you're seeing them face to face or you're talking to them on the phone, they just want their medication and they sort of want to just end the call. But it is really important at this stage that you explore everything in detail. So again, if you look at her age, if you look at the back pain, and if you look at the fact that she's taking all this, she's on a long-term analgesia, and also she's feeling tired and lethargic, it could be nothing, or it could be something quite serious. But again, all of these symptoms combined together can mount to something quite serious. And yeah. Anybody else want to add anything to that before I move on to the next slide?
At room 3. Room 3. Vicky. Asya.
We also discussed looking at maybe a thyroid function, other comorbidities, her sleeping habits, the type of pain she's having, like shooting pain, or what type of pain it is.
Yeah, exactly.
So again, history taking.
Yeah.
And then using the mnemonic as well for assessing the pain.
Yes, absolutely. Okay, so
sorry, just to go on.
Oh, sorry,
no, you do the things to consider, then I'll do that.
Okay, so things to consider. Okay, so back pain is common, but it's crucial to be aware of signs and symptoms which could herald a more serious underlying pathology, or where the cause is more complex than just a simple mechanical pain. So that's what you guys have covered, that what is the nature of the pain? How did it come about? How long, what was did she have a fall? Did she hurt herself in any way? Was it an unexplained back pain that just started overnight? What exactly is going on? Cauda equina can present so this is a discussion we were having in our group as well, that cauda equina can present with bladder, bowel, or sexual disturbances as well. So one of the things that we can ask further. Sorry, is anybody? I think somebody isn't on mute. Okay, no worries. So for example, with cauda equina, I mean, one thing that you can ask the patient is that when you, after passing stool, when you're wiping, can you feel that sensation? And if the answer is no, then that is quite concerning, because saddle paresthesia, or like a numbness feeling whilst, or incontinence when it's whilst passing urine or stools, or even sexual disturbances, can amount to that. And often back pain as a symptom of a malignant spread or myeloma remains when patients lying down. In normal mechanical back pain, generally when a patient lies down, they get a little bit of relief, but in these symptoms, they don't get a relief. Yeah, sorry, Khyati, you were saying something?
Yeah, no, go through your next bit. It might cover what I was going to say.
Okay. So red flag symptoms. So red flag symptoms of cauda equina or cord compression, as I'm explaining, saddle paresthesia, immunosuppression, trauma, history of cancer. Again, all of those things you can get from the patient's record. Nocturnal pain, again, another thing that you want to ask is that when the pain's worse? Is it, how's the pain during nighttime? And does it get worse when the patient's done her, like, I don't know, 10-hour shift? Systemic upset, like, again, your general questions of weight loss, fevers, night sweats, and abnormal gait. Okay. Okay, so that's the next study. So anything to add to that, Khyati?
Yeah, so I mean, back pain's really, really common, isn't it? We all get it once in a while, and you'll see lots of patients with analgesia on this. And the approach for kind of any common symptom is what's the most likely thing it could be and what's the worst thing it could be. And when you're taking the history, if you start off with what's the worst thing it could be, then that's a really good place to then make sure you've covered that before you move on to the most likely diagnosis. So the red flags always feature quite high up in history taking for me. Someone's calling in with back pain, the approach will first be to ask about any neurological symptoms, so any numbness and weakness in your legs, any problems going to the toilet, so that's the bowel and bladder deficit, and the numbness sort of in the lower limbs would cover the cauda equina. So numbness, weakness, and bowels are almost like a roll off your tongue in the same way as fever or weight loss and night sweats do. So they kind of come together. And then, of course, those are the red flags for cauda equina, but you're also wanting to, exclude things like cancer and TB and fractures potentially. So just thinking about what's common. So common is lower back pain. Right, so when people say I've got lower back pain, it worries me a lot less than if someone is saying that they've got thoracic back pain or upper back pain. That's quite unusual. So it's worth starting to develop an idea of what's normal and what should lead to a higher index of suspicion. So where it is in terms of location. The other thing is it's not just cancers we're looking at. In London, people have TB of the spine. So the weight loss, fevers, night sweats covers a lot of that as well. So it's important that the differential diagnosis is broad, that we start off with excluding the more urgent things first, and then moving on to the commoner things. When you guys are seeing people, and often prescribing analgesia and so on, it's worth just checking that a diagnosis has been given against that. So often what happens is someone will have back pain and they'll be given a trial of analgesia, and that somehow just happens to keep getting re-prescribed rather than someone then reviewing the back pain, right? So make sure that if you're doing sort of a multiple repeat prescription of the codeine or the tramadol, that you look back just to have a look and see that there has been a proper diagnosis made and that it is thought to be musculoskeletal, or that it has, is following the pattern that it would normally follow, or whether it needs further investigations as well. And the other thing with back pain is one of the things we see really retrospectively really often is this nocturnal pain. So back pain that's musculoskeletal usually improves with a bit of rest. Pain that wakes you up in the middle of the night is unusual under any circumstance. So that really does need investigation. So if you are then doing the inquiry, then asking about night pain or pain that wakes people up at night is a really good question. When we look back at some of the pathological kind of back pains, pathological as in sort of cancerous that we've looked at, night pain has featured quite a lot.
I think Simon has a question, Khyati, regarding MRI scan versus bloods.
Go for it.
Yeah, so I've seen two different ways of people dealing with back pain. So some people do, the appropriate blood plus a myeloma screen. Other people just do an MRI scan. Obviously we've got easy access to them relatively easy access to Hamlets. Would you just do the bloods and then go from there, or which way around, or neither? Which way around would you do
it? What if I was suspicious of myeloma?
Yeah, or if you're suspicious of cancer.
If I was suspicious of cancer, I would probably do bloods first and then refer based on that. Probably if they fit the criteria, because if it's the bloods that are required for the criteria, required for the 2-week wait referrals, bloods and urine potentially. If the bloods are normal but I'm still suspicious, then I'd probably do the MRI after that.
Great, thanks very much.
Before we move to the next case, are you about to move to the next case, Maria?
Yes, I am.
Should we just stand up and have a bit of a stretch led by you and Khyati?
All right, then. Okay, shall we do that now before the third case?
Yep.
All right, okay. Oh, geez, I'm not ready for this. Okay, so full blood count and well, basically blood test and review of iron tablets. He mentioned that the iron tablets have been making him feel constipated. What would you like to know? Let me just quickly. Okay, so this case is a bit of a. Let me just take a picture and send it. So this case is a bit of a quite ambiguous, and it's sort of like one thing leading to another. So yeah, let's see what you guys make of that.
Maria, should we take feedback?
Yeah. All right. Okay. So, yeah. Would anybody like to volunteer, or shall we pick a group?
Yeah. Say one.
Yeah.
Krishna's group. Krishna,
yeah.
Yeah. Go for it, Krishna.
So we were saying things that we would want to consider if it was a recent change in bowel habit when it started, so the onset and the duration, and also we would want to know the results for the blood test to see if his anemia has actually been treated and if he has been taking the iron tablets or if he's recently started taking them. Because if he feels constipated, usually we would say that it would happen when he's first started the medication instead of later on. And if there's any other kind of associated symptoms, so night sweats or any weight loss, how's his mobility? Has he been less active? And also kind of check the reason he was started on the iron tablet. So was it anemia investigated? Like what was the cause of his anemia? Those are the kind of things that we spoke about, discussed, yeah.
Yeah, absolutely. Yeah, so we will be, first of all, a 74-year-old male with anemia. Why? What's the reason behind it? Also, constipation. Another point that my group raised was quite interesting is that we need to, when patients say they're constipated, we need to sort of find out exactly what they mean by that. Like I think it was Kiloni or Aisha or Sidra said that somebody's constipation could be somebody else's diarrhea. So again, their bowel movements and bowel habits, and are they only if it's not normal for the patient, then you would consider whether they're constipated or not. And was that a constipation? Had he always had constipation, or is it due to iron tablets, because by looking at this, I mean, anybody will assume that, oh, it's very like a normal scenario that we come across, that somebody's been starting iron tablets. Common side effects, yes, of course, it's going to cause constipation, where it can just put them on a little bit of laxatives. But then, what if the constipation was always present in line with the anemia, and it isn't a new diagnosis? So yes, we will again do a very good take a good comprehensive history, and just really explore that. Or is it the anemia? Does this have any malignant source? Like, what's going on with that? And then you're treating with iron tablets, but then the constipation, has that always been present, or is this a new thing? And how long have they had that for? Yeah, so that was very good. Krishna, anybody else? Anybody else like to say anything?
About Sunil's group?
Sunil was in my group. So.
Oh, okay, sorry. Okay, let's go back. Vicky's group, room 3. Vicky? She's not there. Sadia? Room 5?
Yeah, we were saying the similar things, especially with the anemia. What is the cause of it if it's unexplained? Needs further investigation. And another point that we raised was when we do get blood test results back and we see, for example, low ferritin or low HB, instead of quickly giving out or issuing iron tablets, do we need to do more investigations before we give iron tablets on prescription, just to rule out anything else beforehand, any malignancies or anything suspicious, especially in this case for a 74-year-old man?
Yeah, absolutely.
Anything else from maybe room 6? Dennis? Sangeeta?
You said pretty much the same, you know, change in bowel habit, review blood test, considering whether the anemia is just a side effect of iron, or so that's there's not really anything new.
Yeah. So
perhaps, sorry, go on, Maria.
Sorry, I think we are all sort of along the right lines. Sorry, carry on, ask it.
So I just want to add, I think one of my team members mentioned that to make sure to check other medications the patient's taking, for example, NOACs, or any other anticoagulants, or maybe the patient had, you know, any other red flags, for example, is it just constipation or any other, you know, symptoms with the constipation, i.e. blood, while passing bowel. So making sure that we are, you know, looking after those red flags as well. So, and obviously making sure that this constipation is either the new constipation or is it like a previous history that he has got it.
Yeah, absolutely. You're right. Yes. So, yeah, so red flag symptoms: change in bowel habit for more than 6 weeks, persistent rectal bleeding. Again, I think all of you have mentioned most of these things here. Weight loss, night sweats, appetite loss. And again, whenever we are checking all of these things, we need to consider something which is not normal for the patient rather than something which is textbook abnormal. Family history of colorectal pathology. Again, you can get that from patient record. Bowel distension, pain, vomiting, abdominal bloating, and then maybe on new onset confusion, especially for if it's an elderly patient, and any significant weight gain or weight loss, which is unexplained. So yeah, so you all, yeah, it's brilliant. Like, you all were along the right lines for all these 3 case studies, which is great. And I think it's all starts with, as Khyati and all of you have mentioned, taking a comprehensive drug history take, all these different questions, trying to rule out as much of the sinister issues as you can before reaching a conclusion or before reaching a decision that what you will be doing next with the patient. So just very briefly, this is not
sorry,
an
Maria, just before you move on to the next ones, can I just unshare screen and share a 2-week weight referral form?
Yeah, of course, I've done that.
Can I not share screen?
You should. I stopped sharing.
Should
be your co-host.
Have a look.
Yeah, can you guys see that?
Yeah.
So this is what they look like. Pan London. This is the lower GI referral form. And on here, you can put things like if there are safeguarding concerns, if they need, if they need an interpreter, if they've got learning disabilities, all of that can go in there. So for this particular case that we've just discussed, Maria's just discussed about the 74-year-old patient with anemia. I mean, unless you're a woman who has periods regularly, there has to be a reason for the anemia attributed before someone is prescribed iron supplements, okay? And particularly as we get older. For bowel symptoms and for iron deficiency, the changes that have occurred recently relate to the FIT test. And I don't know how many of you are used to ordering or know about the FIT test. And this essentially now, what the criteria is that if any one of these symptoms occur, so the mass, the rectal bleeding, the change in bowel habit, the iron deficiency, anemia, or even the non-iron deficiency anemia, abdo pain or weight loss, someone should be, they should be offered a FIT test before referring to assess for a colorectal cancer. So actually, if there is suspicious, then whilst you're waiting to, if they meet some of these criteria, there's no reason why you can't request a FIT test to happen, and then only refer the patient urgently if the FIT test is coming back raised. So that could be something, you could either discuss whether a FIT test is warranted or request the FIT test. The only other thing I would say is in these patients, they all really need a face-to-face examination. So they need to be brought in, someone needs to palpate their abdomen and do a rectal examination in the majority of cases, because actually if they've got a rectal or anal mass, they don't need any testing, you just send them in. And the other thing to remember is that bowel cancer is growing in young people as well. So it's one of the fastest kind of growing numbers, and I'm not sure why that is. I think the jury is a little bit out as to whether we're just getting better at diagnosing or whether there's external factors, but it's one of the ones that we're seeing a lot more in younger people as well. I mentioned earlier about I mentioned earlier about the conversations you'd be having with people when you refer them in. So one of the things that you put on here is if they're fully active or not, which means this helps them, it helps the clinician on the other end determine whether they can go straight for a workup or whether they need like a pre-assessment before that as well. So that again goes on the referral form. And then suitability, again, for different pathways. So you can put on here if someone has dementia, learning disabilities, and so on. And then finally, the bit that I was saying to you about safety netting and so on. So something that we have to tick to say we've discussed the possible diagnosis of cancer with a patient. The patient has been advised they'll be contacted within 2 weeks, that they should prioritize the appointment. And this thing, the patient has been added to the practice safety netting cancer tool. So if you guys are not used to doing cancer referrals, it's really important that you're aware of this before you start doing any of this, because any patient that's referred on a 2-week wait, there needs to be a process within the practice whereby if they haven't been seen within 2 weeks, the practice can call the patient. So what happens at St Andrews, what used to happen at St Andrews, is that we used to practice note ourselves to remind ourselves in 2 weeks to go back and check into the patient's notes to see if they've been seen. Now there is a central place where this happens. So any referrals that are made by the secretaries go onto a spreadsheet, which is then checked on a regular basis to see if the patient's been offered. And then similarly, now lots of people are using the EMIS safety netting tool, whereby a search is run every day or every week to make sure that all the patients that should have received an appointment have done. So it's really important to be aware of kind of this process safety netting as well. So this is a pan-London form, like I said, so it should look the same wherever you are. It's a pan-London form, and most of these are.
Khyati, sorry, Sabina is asking if you can show everyone where you can find that form.
It might differ from practice to practice, but for Mickey Mouse, sorry. what I would do is go on to documents, create letter, wait for about 5 minutes. And then in the document section, if I type in 2WW, 2-week wait, it gives me all the 2-week waits. Have I stopped sharing screen?
Yes, you have stopped sharing.
That's a bit rubbish, sorry. So from here, if you're going into documents and you type in 2WW, 2-week wait, here we've got all the 2-week wait referral forms. So, and of course, there's a suspected cancer of unknown origin one as well. So these are the people who've got night sweats, weight loss, look cachectic, but you just can't figure, you know, you don't know where the cancer is coming from because they haven't got a rectal bleed or they haven't got an anemia. And this is where they go and have like a scan of everything, basically. So yeah, so there's the urology, upper GI, skin. Skin is now asking for photos as well. So if you're seeing anyone with suspicious lesions, just take photos. It's great for sharing with team members. And all the other ones are there as well, yeah, including children. Does that answer the question?
So is the Pan London form inside here once you click on 2-week wait?
Yeah,
Okay.
if you search 2-week wait in your documents, your referral documents, it brings up all the 2-week wait forms. That's for here, and I think it's pretty much the same, but I'm not sure if how much it differs outside Tower Hamlets.
System 1, so mine will be completely different, but
the form will look the same. How you search for that form might differ.
Okay.
Okay. Right. Okay. So let me just share my screen again. So what I'm going to do is, so we are coming towards the end of the session, but I just wanted to put these next 2 slides together for anyone. It's not an exhaustive list. I will not be going through every single one of them, but it's just a red flag symptoms, and it's just a rough guide which may necessitate any referral. So it's been broken down into your respiratory, oral, upper GI, lower GI, and skin, renal, head and neck, and breast. So if you guys want in your own time, you can just use this guide and refer back, because it may be that there's, as I said, there's so many symptoms, there's so many red flags that it can be quite hard to keep track of everything that you're trying to look for. So this could be like a quite quick and simple guide as well. Okay, so in the end, what Khyati actually thought would be a good idea, if anybody has any stories of like where they picked up red flags and it ended up being something quite serious that they would like to share, I think that'll be quite interesting to just like learn and just see how people went about doing that and what happened, or even not if themselves, but something happened in their practice that was nothing to begin with, but then it ended up being something quite complicated and quite serious. Does anybody have any stories like that they would like to share?
Simon says he can think of one.
All right, okay, go on, Simon.
Yeah, so just on the iron thing, just because what I was saying in my group is I find when we do a medication review, often we think, oh, they're on iron, that's not a big thing to worry about. Actually, I think it's one of the things that you spend most of the time on. I had one case in particular where someone was on iron, it wasn't then rechecked. I rechecked the levels and did a fit test, and it was plus 200, which means it's very likely there's cancer. So I haven't got the outcome yet. There's just the patient's just had an MRI scan, which shows a mass. They don't know what the cause of it is yet. But I just think iron is a big. I do find it a what's the word, trap. You know, in case an extra careful. It's easy to miss off in the middle of the diabetes and that CAPD and everything else.
Any other good examples?
All right, okay, I think, yes. Any other examples, anything else anybody's seen or heard in their own practice? Khyati, do you have any interesting stories that you'd like to share?
Yeah, I've got 2 relatively recent ones. One was an elderly lady who came in to see me about something really minor. I think I mentioned this to Maria, and she just had bruises all over her body, on the abdomen. So leg and arm bruises, I can, maybe swallow, but she had bruises elsewhere. And so initially I was wondering whether she was being beaten up, whether there's an adult safeguarding issue. She had no other symptoms, no other red flag symptoms, but with old people and spontaneous bruising, no medications for it, not really, falling over or anything like that. I got her some urgent blood sort of there and then, and checked the bloods before I went home that day, because often you can check them on the hospital system if they've been processed. She ended up having a leukemia, and the fact, and quite advanced aggressive leukemia, which was causing problems with her bone marrow, which meant her platelets were low, which is why she was bruising, and she was anemic as a result of that as well. That one I won't forget in a hurry. There was another one who was just a man in his 50s, a smoker, who came in with persistent diarrhea, which was a change for him. So about a 4-week history of diarrhea, going about 5 to 6 times a day, no blood in his stool, but I palpated his abdomen and could definitely feel a fullness in his right lower quadrant. And he ended up having a cecal cancer. So he had a colorectal cancer, basically. And he would have fit the criteria for 2-week wait, but you could I could prepare him for that diagnosis. I could say to him, look, I can feel something in the abdomen that doesn't look right. I want to make sure this isn't a cancer if it is, and have that sort of conversation with him. So yeah, two big ones. The other one that often worries me, and this was ages ago, is patients on multiple blood pressure medications, young people on multiple blood pressure medications. And these are ones that you can't get under control. This was a 42-year-old with blood pressures that were on, I think, 4th medication or something like that, and hadn't been investigated yet, started having headaches, sweats, and ended up being diagnosed with a pheochromocytoma after. And that wasn't a 2-week wait. That was more of a, I'm going to send you to clinical pharmacology for further investigations as to secondary causes. And you do worry about pheos in patients, particularly if they're getting headaches and sweats and their blood pressures not being controlled and so on. But that wasn't a 2-week wait. So that was one for reflection for me.
All right. Okay. Wow, that's really interesting. Anybody has anything else that they'd like to share?
I had one, a 6-year-old which was newly, well, her HbA1c was checked as a routine checkup, and she was not diabetic before, but it spiked to 70 odd, and I think someone started her on a metformin straight away, but she was complaining of vomiting, diarrhea, constipation, diarrhea, vomiting, so gastric kind of symptoms, which are commonly known with metformin. Then it further investigated that it was pancreatic cancer. And unfortunately, she passed away after probably about 6 months.
I'll ask a question about that, actually.
Sure.
So with so there's no, I don't think that there's any criteria specifically for pancreatic cancer, as far as I know. And often my understanding is that we find it when it's too late, and or if someone has jaundice, for example, at that point it's too late. I mean, if I have occasions, especially over COVID, where sugars have just gone mad, just shot up, I suppose maybe Chandni also would see what you think about this. Should we be, should we be safety netting for pancreatic cancer? How would we do that?
That's a tricky one, isn't it? I I'm just bringing up the 2-week weight criteria. Give me one sec. So it's here. Can you see it? Have I shared?
Yeah, we can.
Yeah, so pancreatic, liver and gallbladder. So you're looking at an ultrasound suggestive of that.
Okay, that's
age over 40 with jaundice, a mass, which is really important. So, you know, the abdo-palpation bit is really important. And these systemic symptoms, the weight loss, abdo pain, diarrhea, constipation, nausea. So it's the weight loss that would make you suspicious. But you're right, at that stage, you know, it could be quite far progressed.
Couldn't the weight loss just be caused by the diabetes as well? If it's that high?
What could be caused
by HbA1c is really high. Could that in it of itself cause weight loss, which is like a which could get in front of the, which could what's the word, shadow the diagnosis?
Yeah, it could, couldn't it? But I think anywhere where people have got significant weight loss, you would want to rule out a cancer before you put it down to something else, probably. And that's probably the normal way of doing it. You know, what's the most serious thing it could be, and then what's it most likely to be. So rule out the serious thing and then carry on with your more likely diagnosis. But yeah, so there are some criteria for it, but yeah, often with these criteria, it's progressed a fair bit by the time you get it.
Okay. Well, we're coming up to 4. We nice to finish a little bit early. Allow people to have a break before they go back to work. Anybody got any general questions for Khyati or Maria? Not necessarily about red flags, but about anything which is, you know, happened recently that they want to discuss or get people's views on. If so, just unmute and speak. Is there any news? I'm going to ask a question in the absence of QOF and NIS and all of that. Is there anything?
Yeah, I've been told that there is definitely a pause on medicines NIS up until July. And the reason for that, for locally here in Tower Hamlets, is because the merging of 7 CCGs into NEL, and now they're trying to align the process for NEL. And so there won't be anything until July, which is great in a way, that we can just sort of prioritize the things that we need to prioritize. So I'd say the SMRs, the radar safety netting stuff, the radar tools, sorry, would be the things to do whilst we're waiting for any guidance. The QOF stuff's all there, and the things related to medicines will probably be things like, I can't remember off the top of my head, but it's the usual stuff that we've always dealt with. So the blood pressure targets, the diabetes, HbA1c targets, all of that's back in play from now, from April onwards.
There's a NIS meeting tomorrow. Is that going to cover any of this stuff, or?
Yeah, I'm doing the NIS meeting tomorrow. Yeah, so it's only going to be covering NIS stuff really, and from a medicines perspective, there isn't that much that the ICCQ NIS is covering, because the medicines NIS is separate. So the only bit around the medicines NIS is the fact that there is a pause in it till.
Do we need to watch it, or is it not really going to be that relevant then to pharmacists?
Probably be really boring if I'm delivering it. It's
no, not.
So the bits that might be relevant is the work around hypertension monitoring for some of you guys who might be involved in that. If anyone's involved in integrated care patients, then there'll be a bit around that. So restarting that. If any of you are involved in monitoring renal function and declining renal function within the practice, which actually could sit really well with you guys, the renal trigger tool work, which was happening previously, is going to be back. And then the other thing that will be relevant to you guys will be around monitoring of patients who are on antipsychotic medications. So actually, yeah, lots of stuff will be relevant.
Loads of things.
Yeah.
I'm sure
I was going to say stay away, but actually, no, come join me.
I wasn't implying it was going to be boring. Sorry if that.
Well, as exciting as NIS meetings get, really. But yeah, I'll try my best.
Okay.
Khyati, sorry, quick question. It'll be my first time joining the NIS meeting ever. How do I join?
Hi, Matiba.
Hi, Khyati.
Join onto a computer with someone else who's got the link for it, register for it, and then you get a link sent to you.
I'll put the link in the chat anyway, in case you can't.
Thank you.
You do have to register if you're not sharing a computer with someone. I think so, because I think there's only like limits on the number of people you can.
Okay, I'll need to become a parasite.
Yeah, I mean,
here we go. I'll send you the registration link then.
Okay.
I can't remember if there was a registration link or not this time, but yeah, they normally, if you register, then they normally send you a link.
All right. Thank you.
Excellent. Thanks, everyone.
Thank you.
All right. I've just put the link to the survey on the WhatsApp group. We've everybody's got very busy, understandably, and so people are rushing away and not completing the survey. It is helpful for people to know, and some people are, for example, completing portfolios and want to be able to add the feedback to that, and also we use it to plan the next round. I'm about to start planning the next 6 months of training, so I know at the end of those forms there are suggestions are made, and we do collate them, and I will use those. So, but if you have anything that's front of mind, please add it to this week's survey. That would be fantastic. Thank you, Khyati. Thank you, Maria, for all your hard work. It was a really, really good session. I think we've all benefited, and hopefully we'll say that in the feedback. Excellent. Thank you, everyone. Have a good afternoon.
Thank you. Bye.